Welcome back, everybody, to part 2 of the Animal Heartbeat Christmas Special quiz. I am Kieran Borgeat, veterinary cardiologist, currently showcasing his lack of knowledge on the Animal Heartbeat Christmas quiz. I am joined by Professor Jose Novo Matos, our quiz masters, Caroline Cutler, second-year resident in cardiology, and Eve Lowe, also second-year resident in cardiology. They are here to teach us about cardiology. Jose, how are you feeling?
Yeah, still very nervous. Didn't really improve after the first episode.
Worse
yeah,
for me.
thanks for the cases. Very, very, very. Yeah, we have been seeing interesting cases and sharing cases and experiences. So very cool. Caroline and Eve have been fair to us with their grading,
harsh but fair.
scoring,
harsh but fair.
And so yeah, looking forward to see what comes next.
Just to remind the listeners, if anyone hasn't listened to yesterday's episode, please do go back and listen to that because you'll hear the first part of the quiz. You can play along, which is really the fun of it, rather than listening to us struggle. You can struggle too, and look at the images and the videos as you're listening. The links are all in the podcast episode details. Who have we got next? What's happening?
So I was just about to tell you how many points you had scored for the last question.
Crikey.
You actually did a lot better than you think you did.
We always remember the bad stuff, right?
You had, I think, if I put you down for 4 points, the ones that you missed was the fact that it was a PFO, but you noted the aberrant azygous vein branching into or emptying into left atrium, which is valued at 2 points, and as well as the core tracheatum dexter and the persistent eustachian valve, which is another 2 points. So 4 points for that out of 5.
It's respectable. Thank you. Thanks, Eve. Right, it's Jose's turn next.
So yeah, question 4. So you have a 10-month-old male entire French bulldog that is presented for cardiac evaluation, and we have provided you with 2 angiographic cine loops, and we would like to know your findings in this case, please. Firstly, for video 1, and then for video 2.
So nothing on clinical examination, nothing, just, yeah.
No.
That's fine.
Nothing.
That's fine. So, I'm looking at an angio. We see a catheter coming through the craniovena cava, looks like a flexor, that is just at the level of inside of the craniovena cava, right atrium. And then there's a balloon tip catheter, an angiographic balloon tip catheter, like a Berman catheter, as it seems, and an angiography. So this catheter is at the right ventricle. So catheter, flexor-like catheter, craniovena cava, and then close to the right atrium, and then this balloon tip catheter, angiographic catheter, and we see an injection that has been done in the right ventricle. So we see contrast straight away in the right ventricle, pulmonary artery, but also the aorta. Yeah, trying to be fast, I think this is most likely a right to left ventricular receptor defect. So there is an intracardiac communication between the right ventricle and the left ventricle. So the contrast shunts very, very quickly. As soon as the right ventricle is opacified, we see straight away contrast in the LVOT and aorta. There seems that it's difficult to assess the pulmonary artery valve, because then you see the aorta straight away. The aorta is superimposed, but I think there is post-stenotic dilation. The pulmonary artery is dilated, so the right and left pulmonary branch are dilated, and the main pulmonary artery is dilated, so there is clear post-stenotic dilation. So I would go that very likely this dog is a pulmonary stenosis. I think valvular stenosis. Then we have a second angio. In this case, we see a pigtail, and the injection is done at the aortic root. So a pigtail that comes through the femoral artery, descending aorta, ascending aorta, and the contrast is being injected at the aortic root. So in this case, we don't see contrast in the right side of the heart. So again, this was a right to left ventricular receptor defect. As is a bulldog and has pulmonary stenosis, I would like to look at the coronary arteries to see if this could be a single coronary artery anomaly. I see very well the right coronary artery. I cannot see the left coronary artery that well, but might be just the image potentially. I go back to the other angio. Here again, I can see very well the left coronary artery. Doesn't strike me, again, it's difficult to assess the pulmonary valve and the subvalvular and subpulmonary area or infundibulum to see with a single coronary artery anomaly, pre-pulmonic coronary artery, we'd expect a subvalvular stenosis. I don't see that clearly. So just based on I don't see well the left, I cannot see the left coronary artery, but based on how the angio looks like, how the pulmonary valve looks like, based on what I can see, I cannot see a clear single left coronary artery anomaly, but I would not be entirely sure if I can exclude that because I cannot really see the left coronary artery. So otherwise, so in summary, this dog has severe pulmonary stenosis because there's suprasystemic pressures in the right ventricle, and the right to left, what seems to be a right, I'll go with the right to left VSD. Seem to be perimembranous, doesn't seem to be muscular, so I think I will go with the perimembranous VSD based on where I can see the contrast in the left ventricle. So yeah, so I'm not entirely sure if there's a coronary artery anomaly or no, but my main diagnosis would be severe pulmonary stenosis with the right to left VSD. I don't see other stuff like PDAs. Yeah, I think I would just for a sake of time, I would just that's my final assessment.
So a fair approach. So we will have to, I'm afraid, deduct 1 point because this wasn't a cranial approach. This was a caudal approach. So
yeah, but he meant a caudal approach.
Yeah. You mean the flexor? Yeah. You're right. No, that's fine. That's fine. No, that's fine because it's coming exactly the same direction as the pigtail.
You said
that's fine.
You said cranial, but you didn't think it was the cranial cava, right? Because you didn't go, hang on, the angles are really weird. What's happening here?
No. But that's fine. That's fine.
That was a slip of the tongue.
Okay. All right, we can give that.
Listen, I'm all for him losing points, but legitimately, okay? I want to win fair and square.
Okay. So this was an angiogram from a venous approach, and the first thing we did see was that contrast appearing in the right side. So we saw a pacification of that right ventricle followed by the pulmonary artery. As you said, we did see a right to left shunt at the ventricular level. Again, as you stated, the pulmonary artery does appear hyperplastic, and we do see some post-stenotic dilatation, so a pulmonic stenosis is suspected. What I don't think you stated was that the position of the aorta and the pulmonary artery aren't as we would expect. So there is a cranial malalignment of the aorta, and it's quite parallel when comparing it to how the pulmonary artery is coursing. And then in video 2, as you said, we can see the right coronary artery. You said very clearly. Kieran's gone for subjectively large, but I think that's saying the same thing. And as you stated, it doesn't appear that we have a pre-pulmonic course, so lack of concern if we were wanting to balloon this dog.
So I think there's a conotruncal malformation there, and given the right to left shunt in the ventricle and the relative sort of hypoplastic appearance of that initial pulmonary trunk, I've gone with tetralogy on that.
Yeah. I just like to see an infundibular narrowing. I'd like to see if there's true dextroposition of the aorta. Yeah. I like to see an infundibular narrowing.
And we don't have a left ventricular
which we don't. Which I don't know. It didn't seem so, but I don't know. I think it's sometimes it's difficult, but I agree with your assessment. I think that's fair. That's cool. Yeah, absolutely.
When we did this case initially, the reason we cut down and did the aortic root injection is that first flash of a pacification of contrast up through the RVOT and the pulmonary trunk. You can see that right coronary from there. Yeah. And I thought, oh, hang on, is that coming off the pulmonary artery? But it's clear from the aortic root injection, it's not an aberrant coronary from the pulmonary side, because that is, that is possible. Yeah. And I agree. I don't think it has a pre-pulmonic course.
Cool. Yeah, nice answer. So how many points did I score? 4.
Well, I think 4 out of 5. I think.
Yeah, that's good. Yeah, that's fine. Okay. Why then? Because of the dexter position, or no, because I call it cranial?
Well, you didn't. Well, I don't know. We can debate it because we didn't call it tetralogy for certain.
That's okay.
You see,
Do you want to go 4.5?
having written the
Oh,
You can't
question,
have 5. You can't have 5.
because I've said likely diagnosis is tetralogy
have
of valve
likely.
of fallow or VSD with PS.
Because tetralogy of Paulo is yeah. I think to diagnose it on an angio to assess the extra position of the aorta. Yeah,
So you
I'll
guys,
go
the
with
quiz
half.
masters, look, I'm trying to
Come on,
I'm trying to win
four
friends.
point
It's a fair-
25. Make it 4.25.
I think
It's really hard-
technically,
it's
if you
hard
also
to-
not technically, if I'm not saying it was a malalignment VSD, I think you also can't really claim it's a tetralogy without saying you're all 4. And what really makes it a tetralogy is the malalignment VSD in the first place. So even if you had a VSD but was a malalignment one, then you don't get the point for. If we're really
All right,
calling.
give him 5. Give him 5. It's okay, fine,
4.5.
whatever.
4.5. No, I'm fine. I'm fine too.
I think I feel more comfortable with 4.5.
Yeah. No, in fact, I think the tetralogy of Fallow I would fight back is more that I did say cranial twice, even though I didn't mean that because the cats are coming. But that's wrong. That's wrong. So I should have been more careful. So I would rather lose a alpha point there than with the tetralogy, I think.
So the next question for Kieran,
Okay.
it's one of my favorite things actually, is a case on looking
Hang
at
on, is it brown paper packages tied up with string? Sorry.
No, it's not. But this is there's not a signalment in this question, but it's just asking you for what's happening in the M mode and mitral inflow profiles. These are of two different of the same phenomenon.
Okay. Right.
And then there's a further question that is in worth 3 points, which is of one echo loop and a still image. But you can go through the first.
Okay. So the first thing I've got 2 images here. I've got one is an M mode of the left ventricle in short axis, the level of the mitral valve. Call it fish mouth, if you will. And what I can see is instead of the normal E and A points of opening of the mitral valve, so instead of a biphasic opening of the mitral valve in diastole, I can see a third hump or bump or whatever we want to call it there, a third part of the valve motion after the E and before the A. So we can see the E is after the QRST complex on the simultaneous ECG. The A is just after the P wave because that's atrial contraction, atrial filling of the ventricle, moving that mitral valve. So this is after the E, but before the A, and that's consistent where the heart rate allows it, because obviously there will be summation at higher rates. The image on the right, we've got Doppler of mitral inflow. Now it's clearly a different dog. It's not in sinus rhythm. It's in atrial fibrillation. It looks like we've got an irregular rhythm, sort of relatively narrow QRST, no discernible P waves. So I'm going to call that atrial fibrillation. And what I can see, therefore, if it's atrial fibrillation, is no A, and I can see an E, and this additional portion of left ventricular filling is transmitral flow. So we can have various additions to transmitral flow on top of the E and the A. And what we've got here, because it's after the E, the early, this is a late, an L wave. If it was after the A, it would be called the B, or B bump, B wave, or B bump. So the L wave can be associated with high filling pressures. And I'm guessing that's what's happening in the atrial fibrillation case. Another differential would just be bradycardia. And it's something that I think I see in sight hounds and spaniels sometimes. So reasonably athletic breeds without any abnormalities. So I do think we see it associated with bradycardia more than we do with high filling pressure. The B bump, which is the one that's not here, just for clarity, is after the A. We see that more with very high left atrial pressures and a risk of heart failure. I'm just going to plow on through to look at what's happening in the left ventricular Doppler trace. And then you can tell me in a minute how far off the mark I am, although I've spoken very confidently. So I've got a cine loop here and a still image. The still image is a Doppler profile, which looks like a pulse wave Doppler profile of the left ventricle from a left apical 4 or 5 chamber view. And the cine loop, I have got a right parasternal 4 chamber view or 5 chamber view. Watching the cine loop, I'm going to slow it down, but I think what I can see is I've got systolic anterior motion of the mitral valve. There is also what looks like a false tendon or left ventricular band, hi Jens, in the more apical portion of that left ventricle, just below the left ventricular outflow tract. And during systole, the attachment point of that left ventricular band seems to move posterior or in a posterior direction, and the mitral valve looks like it moves in an anterior direction. So we've got systolic anterior motion of the mitral valve. So one of my differentials is going to be left ventricular outflow tract obstruction based on the 2D images. In the Doppler profile on the right, what I can see is a dual profile that shows late systolic acceleration of flow. And it looks like they're in two different locations. Presuming that's reliably interrogating the outflow tract, there may be a component of that outflow tract obstruction on there. But I'm going to be thinking about mid-ventricular obstruction as well. Because in cats, we can get mid-ventricular obstruction caused by large papillary muscles or patchy hypertrophy or left ventricular bands as well, which may be distant to the outflow tract. So I think this double profile we're seeing here represents mid-ventricular obstruction. And perhaps if the cine loop is the same case, that is associated with left ventricular band or abnormal papillary architecture. Eve, how did I do?
But you got everything right from the first question. Did he mention the lobster claw?
There was no mention of lobster claw.
Oh, no mention of lobster claw.
And I haven't heard of a lobster claw.
I heard of it because Lucas told me about it after what Jose has told him.
I've
Jose
heard
make
of,
up?
And
I've
he
heard
always
of the
goes,
lobster claw, but in relation to
"Lobster
pulmonary hypertension and outflow from the right ventricle.
The name is cool, but I think that's not important to call it lobster claw. I think what Kieran mentioned is really important. So Kieran mentioned that the sample volume of the pulse wave Doppler is mid left ventricle in the
That's
apical
right.
view.
Yeah.
So I think the first
true.
differential diagnosis would be certainly a mid ventricle obstruction. We have a patient with hypertrophic cardiomyopathy, systolic anterior motion of the mitral valve.
It's not very obstructed though in terms of speed, is it? There's not a huge pressure gradient, but I think we often do find that with these mid-ventricular obstructions.
Yeah. So, but a lot. What is special about this profile is so the systolic flow is suddenly interrupted and then restarts, and that's the definition of lobster claw, where there is a mid-systolic afterload mismatch. So when the left ventricle contracts and at the peak of outflow tract obstruction, the higher outflow tract obstruction, left ventricle outflow tract obstruction, the cardiomyopathic left ventricle cannot overcome that afterload. So there is a decreased systolic flow, and then the systolic flow, as soon as the ventricle is able to overcome that increased afterload, then there is again flow. So in the case of severe left ventricular outflow tract obstruction, there might be, you may see this mid-ventricular gradient or this mid-ventricular pattern where there is a sudden interruption on forward flow due to afterload mismatch. And that's in humans, that's associated with decreased longitudinal systolic function. So just because I think this is funny, whenever I have obstructive cats, I generally look at for these mid left ventricle signs of afterload mismatch. And so this lobster claw is because the profile looks like potentially a lobster claw.
And do you see, do they have a like a pulse with a bisphorons profile, a double peaked pulse as well?
Exactly. And in this case, what happens also is when we do a aortic valve M mode, you see that the aortic valve slightly closes in the middle and then opens again, because that's what is happening. There's a decreased forward flow during that moment that the ventricle is not able to overcome that that afterload. And then the valve opens again. So this generally associated with that mid-aortic valve closure.
Yeah, I've seen that in dogs with very severe subaortic stenosis. Yeah. But yeah, super interesting.
Cool, but you did very well.
I think is this a 5 out of 5? I think you pretty much got everything. If we're not going to
it's just this is not mid-left ventricular obstruction.
No, okay.
It's a particular mid-ventricular obstruction plus outflow tract obstruction, right?
Yeah,
that's what I've missed there. Yeah.
Okay, so 4 out of 5.
Yeah, sounds very fair. Yeah.
Great.
Are we neck and neck? We're pretty close, right?
You're pretty close.
Okay, great.
Nice.
Jose.
So maybe
the final straight. This is your chance. This is your chance to knock me down and leave me for dead.
So case number 5.
So this is in the impossible category, but maybe you read about it last night, so be fine.
Well, that's it. You see, Jose might be publishing on it next week, for all we know.
For me, it's certainly challenging. So a 3-year-old female neutered terrier cross presents for evaluation of an incidentally detected heart murmur. So part A is describe the abnormality. Part B, using the classification system in humans, identify which class of this disease is present.
You love the human classification system.
Absolutely. I like this. No, this is stuff I like. So I see. So I have a video loop of a right peristernal short axis view at the heart base. So I see the aorta and the left atrium. The left atrium is mildly dilated. So LAEO seems increased. And then the aortic valve is not tricuspid, seems to be bicuspid. And they have a diastolic and a systolic frame, steel frames. So it seems to be a bicuspid aortic valve. Just slow it down to be sure it's bicuspid, not unicuspid or some crazy stuff. I think based on the steel frames, I think it's bicuspid. So bicuspid aortic valves are the most common congenital heart defect in humans. It's generally associated with aortic regurgitation and/or aortic stenosis because they calcify over time. Then, so besides the steel frames in diastole and systole, which I think shows that bicuspid valve, then we have a subcostal view with continuous wave Doppler measuring peak LVOT velocity, so transaortic flow velocity. And we have a transaortic flow velocity of 2.5 meters per second. So suggesting the left ventricular obstruction or valvular, in this case, likely a valvular stenosis. So this bicuspid aortic valve, hopefully I'm not completely wrong, this bicuspid aortic valve is associated with mild valvular aortic stenosis. The continuous wave Doppler profile doesn't seem that there is aortic regurg. The baseline is very on the top of the screen, but I don't see clearly a diastolic flow, so I don't think there is aortic regurgitation. There is an increased transvalvular aortic pressure gradient. So I would go with bicuspid aortic valve causing mild aortic stenosis. Now, Dr. Skansen and Visser have published these 2 or 3 case report of 2 or 3 cases, I think, bulldogs or maybe one, I don't know, of bicuspid aortic valves. I remember more or less the classification because we have 2 cats with bicuspid aortic valves that we wanted to publish.
I told you.
And the way I memorize these is there are 3 types, and is left, right non-coronary, and left non-coronary thing. So you classify depending on which valves are fused, which if the non-coronary, the left coronary, or the right coronary valves, the tricuspid leaflets, the aortic valves are fused. So if it is the left and the right fused, I think it's type 1. If it is the right and the non-coronary, I think it's type 2. And then the left and the non-coronary type 3, I think. And I think the case they published was either type 2 or type 3. I always struggle a lot by looking at the images, how to classify the cases. I think the ones I have seen either look like a smiley face or look like this, like a straight transverse line as we are seeing. And I think this would be a fusion of the non-coronary and the left coronary, I think. So I would go with type 3, but I'm not sure. I have to be honest, I struggle to know exactly which ones are fused. And I think that also in humans, if you see the rough, I think that's how you call it, if you see the line, you still see the leaflets are fused, but you see the Rafi,
Rafi.
Then I think there's a sub-classification. I don't know if it is A, B, or C, or you should just say if you see the Rafi or no. I think
so. The old classification system prior to 2021 was
is this the old one?
Was type 1, type 2, type 3, depending on which ones were fused and which direction the smiley face was in, because sometimes it was a sad face. And where the coronaries arise from. So where the fusion was. Plus or minus Rafi.
Yeah.
So you're correct about the classification system and what the structure was. But you're living in the past, old man, because
is there a new classification?
the classification system, well, it's not so new, 2021. So it may be that the previously published case report was talking about
Yeah.
the current system when it was published. So the 2021 consensus talks about 3 different phenotypes. Rather than calling it 1, 2, 3, they call it about a fused bicuspid aortic valve, where you've got 3 aortic sinuses, and they commonly have raphe. So this encompasses quite a lot of the original classifications. Then there's the 2 sinus bicuspid aortic valve, which is what this is. This is a 2 sinus form. And then the third group is partial fusion. So these are sort of form frust, if you like where there are 3 aortic sinuses and usually 3 cusps or partial raphe. So the only true bicuspid valves are actually the fused and the 2 sinus. So this is a 2 sinus form, as you say. Take a look at the still images and tell me which cusps you think are fused.
Honestly, I'm useless with that. I spent so many times trying to convince, even with the old classification, I tried to look, I don't know how it's, again, I really, yeah, I don't know. I really struggle to know. I would still go with non-coronary. I think I would still go with, maybe now if you ask, maybe I'll go left and right. But I don't know. I think it's challenging to me to know exactly which valves are fused, which leaflets are fused, to be honest. What did you call it?
So with the classification system, I called it a 2 sinus bicuspid aortic valve. And I'm going to send a link to an image of the classification system as well on the podcast description so people can see this. The specific phenotype would be lateral fusion. So as you identified, the commissure of the 2 cusps of this aortic valve is vertical within that slightly ellipsoid looking aortic annulus. And I think if you look at the still image, there's diastole and systole showing the valve closed, valve opened, and how those leaflets are fused in the open position. But if you look at the image at the bottom left of those 4 stills, so on the left of the continuous wave Doppler, I think you can just see little thready coronary arteries, both coming from the right side of this lateral fusion. So I think here we've got fusion of the right and left coronary cusps, and the non-coronary cusp is independent and non-fused.
Cool. Yeah, I think that's a fair assessment.
Do you buy it?
Yeah. Caroline?
Well, I don't want to be too negative. I feel I'm being very negative now, but there's a strong 2 out of 5, but I don't know if we can give you any more, because the question did state, well, we said human classification, but we didn't specify the year.
Oh, come on.
Fair. We didn't.
Come on.
We can't allow to use the 1973 classification of something.
Yeah, that's true. And any exam would assume the most recent document.
I would say, and listen, you guys, Eve, Caroline, you decide. Okay. Personally, I'd give him a 2 plus a bonus point, because I think he was remembering the old classification system, and props for that. That's good. That's good.
Okay. 3 out of 5.
You are being so tough, so hard. Come on. Nah.
Hey, listen, it's not me. We've got an independent panel here.
I think, I don't know.
I'm never going to get 3 on your next question. Based on what I've seen so far, I mean, to be fair, I think your question 3 and 4 are the wrong way around, personally. Although 4 was challenging the lobster claw. Come on. The lobster claw in the left heart. Okay.
I'm sticking with 3.
Steal myself.
Eve, come on, it's 3. I use a classification.
Bonus, so it definitely is a 3. At most, it's a 3.5. But I mean, your next one for Kieran, the history does start with history from the farmer. So I think
what? Just because I am ACVIM does not mean I know about large animals. It means I passed an exam featuring large animals. Although I have published in, is it a calf? I've published in calf cardiology. I have published in calf gross path in vet record.
It's a huge advantage.
You give me a calf.
This is of a calf, so I think you'd know what you
what? Can I retract my comment about having published on it before?
So this next one
take a
for you is a 5-day-old calf. History from the farmer is calf was born normal, suckled dam, and was bright, alert, and responsive, but then 5 days later was found dead, and no veterinary clinical exam was performed.
Upsetting. for many reasons, but upsetting
have
for me
here a
right now
bunch
because of
of-
the lack of an exam.
This
and
is
you
real
now
life.
have a post mortem images.
So what we know is it was a species that we know of, and it died. Okay, fantastic. Oh boy. All right. We've got some gross path images. Oh, let's try and orientate myself. I'm so much better with a heart in my hands than looking at the photographs.
No, I agree. I have to say it's really tough to look at just photographs.
It's all right. It's all right. It's all right. I'm
And
there.
I'm sure they will give you 5 because
Yeah, you're killing me. Okay. So I think in the image on the left of this first slide, there are 3 images. The image on the left, we are looking at the cranial aspect of the heart. We can see the right ventricular outflow tract in the near field and what looks like a large pulmonary artery coming up the front of that image. Behind that pulmonary artery, that's an ascending aorta. That is miniature. It's a tiny, tiny ascending aorta. And I can confirm that in the next view. Here we're looking from the right at that heart. And we can see, I think that's the right atrium we've got open there. That chamber we've got open. We've got a tiny looking ascending aorta ascending from the middle of the heart because the aorta is central. And the cranial aspect is the right of this image. We've got the RVOT and a very large pulmonary artery. It looks like the ascending aorta is tiny, but then it looks like there's a connection between the pulmonary artery and the aorta beyond the vessels going to the head. What do you call it in a cow? I mean, it's a brachycephalic trunk. It is a brachycephalic trunk, but it obviously branches differently to a dog or a cat. So if we look at the third image there, we're looking from the cord. No, from the cranial aspect, but slightly more dorsally. We're looking down on the pulmonary artery, down on this miniature aorta, and then actually we can see there's a connection there between the main pulmonary artery, sort of at the level of the bifurcation, and what looks like the descending aorta. And then the brachycephalic trunk going to the head and neck and the forelimbs is, I'm guessing, a normal diameter. So it's the ascending aorta is a tiny vessel. So very hypoplastic looking. Right, the next image is that I've got on the slide. It says we're looking at the left atrium. This is a very trabecular looking left atrium. Is that normal in cows? Can't remember. Maybe. Where's the mitral valve? We're looking down on the what should be where the mitral orifice is, and I think I can see a sort of depression at the bottom of the left atrium there, which looks like either very severe mitral stenosis or mitral valve atresia. Now we've got more images of the outside of the heart. So these images are showing us the image on the left. We've got the lateral aspect of the heart from the left. So we can see the left auricle, which is incised there to open the chamber, hanging down over the AV groove. We can see a large main pulmonary artery connecting with the aorta. The pulmonary arteries branch, or the pulmonary artery branches normally. The aorta, we're looking at the descending aorta and the pulmonary arteries below it in the image on the right here. And we've got a very narrow lumen to that ascending aorta. Okay, we've got mitral atresia or severe stenosis. We've got what looks like a coarctation or got the word for this probably. Yes, a coarctation of the ascending aorta. We've got must have a PDA, which is supplying those vessels to the head and neck, which is obviously not great for your cerebral oxygenation. Probably explains death at 5 days. In this next image that we can see, we've got the left ventricle, I presume, which appears to have muscular bands across it and is very, very tiny indeed for this size of animal. And we have got a connection between the atria. I think it has to be a PFO. I can't see a defect, but I can obviously see a flap here. So maybe, Jose, this is one of those left to right PFOs that you talked about, where the morphology and the pressure gradient means it's essential to maintain flow. I would say that this is a calf with hypoplastic left heart syndrome, which comprises of mitral valve atresia or severe stenosis, left ventricular hypoplasia. There's not enough flow going into it to make it develop, and a coarctation of the ascending aorta. And I think that life was maintained, as far as it was, by flow coming back from the pulmonary veins, traversing the interatrial septum by an interatrial communication. And there's clearly a communication through a ductus arteriosus, which is patent at the level of the pulmonary valve and the descending aorta, which then goes retrograde, if you like, and supplies the head and neck. And maybe when that ductus started to close a little bit, or the calf needed its brain at all around 5 days of age, that's why it didn't survive. Super interesting case. I don't know how close I am to the mark, but those are my thoughts via a sort of semi-sequential segmental analysis of the specimen.
No, you did really well for that one. I'm giving you a 5. 5 out of 5. Because you identified all of the main abnormalities, and also by also identifying the PDA and the...
I'm reclaiming the calf publication.
No, very, very good. Agree.
Then, yeah, it makes sense segmentally working out. So very good. Yep, there is aortic atresia with an imperforate aortic orifice, mitral valve atresia as well, with an imperforate orifice and a hypoplastic left ventricular chamber, as well as hypoplasia of the ascending aorta and coarctation of the aorta, as well as a PFO and PDA to maintain circulation that side, and otherwise the right-sided chambers and right-sided great arteries are normal.
I love a bit of pathology. Great case. What a great case. Super cool.
Cool. I think you won.
No, what are the scores? What are the scores?
Well, before we do the scores,
We might need a pause here so that Caroline and I can chat in the background.
Oh,
Okay.
okay. All right.
1 second.
Let's insert a podcast pause.
What scores did you get to, Eve?
Let me add up.
I got 21 for Kieran versus 20 for Jose.
Oh, I had 21.5.
Before we reveal the scores, unbeknown to you both, there was some negative scoring at play.
Oh, what?
Which we thought was fair. You're both, from Eve and I's perspective, very supportive cardiologists. So we wanted to really help you on your learning journey too. So I've detracted some for you, Kieran, for using the word X-ray instead of the word radiograph. Apparently that was a big no-no at the RVC.
Depends who you talk to.
Deducted 1 for putting no paper speed on an ECG. We really don't like that. It makes it really challenging, and it's not fair. And I
like a challenge.
I deducted 1 point for saying the phrase "alligator closest to the boat."
Oh, come on!
Which no one likes.
Yeah, but I said it for you.
I don't like it. So I'm taking away 3 from Kieran. I don't know how many you're taking away from Jose, Eve.
So Jose have had to similarly with the negative scoring for saying the word X-ray, and you had said that multiple times. Actually, they don't like that. So that's both at the RVC and at Edinburgh. They don't like the word X-ray for thoracic radiograph. Also, then in line with that, the fact that you were so hypocritical with you saying that it's pulmonary stenosis, but then said X-ray multiple times. So that's another scoring on that. Ultimately, I think here I've removed negative scores. You have now lost 4 points from the combination of the two. You did say X-ray more than just 4 times, but that was too many points lost otherwise.
Had to stop counting.
This is harsh.
Which then
really
brings
harsh,
Kieran,
yeah.
who was initially on 21.5. And what was Jose on initially?
20.
20.
So I'm down to 18 for Kieran.
And now Jose's on 16.
Oh.
Come on. You are so picky.
Should we give him the chance? Should we give him the tiebreaker? And
Yes.
if Jose wins, he can have 2 points.
Yeah.
I think, given this hideous negative marking business, which is terrible from an educational perspective, you know, we should never be afraid to get the chance to get stuff wrong, right, on our learning journey. But I think we merit a tie break. We merit a tie break, surely.
Should I read it out? I don't know if I can pronounce this correctly, so that I might embarrass myself quite a lot.
Don't worry, we say stuff wrong all the time.
What is the
So
heart rate?
so we will try to is who answers first, or how does it work? So you ask us a question, and
I'm going to ask you the
we
question,
answer
and
first?
the closest answer wins.
Okay.
Oh, closest
Okay.
answer wins. I like it. Okay, good.
What is the heart rate of the Eurasian shrew, otherwise known as the white-toothed pygmy shrew?
Oh, the white-toothed pygmy shrew. I don't know it. Jesse, are you Googling? Show me your hands. Show me your hands.
Hey Siri.
Don't even joke. Don't even joke.
Is there someone in the room
First.
with you? We should do a 360 camera view.
Oh yeah, like they do for remote proctoring for exams. Of the white-toothed pygmy shrew. Okay. I am going to go with a heart rate of 396 beats per minute.
Jose?
I go with a heart rate of you said 396.
Yep.
I don't know, 300.
So the heart rate is actually 1,500 beats per minute.
Oh!
God,
And there's one in the waiting room to echo. Wow.
crazy. Congrats, Kieran.
After my initial shock, I'm humbled and also relieved to have won. I feel like on a technicality though.
Yeah, I think the guidelines, the classification. I will appeal. I will still write.
Yeah,
an
but you
appeal.
gave me a cow.
The animal heart
gave me
beats.
a baby cow with no history of physical exam findings. Come on,
Well,
come on.
The farmer told you everything you needed to know. Come on.
Well, apparently he did because I got 5 out of 5. So let's just go with that. That's fantastic. Yeah. Fantastic reveal, guys. It's been fabulous. Have you enjoyed your first Animal Heartbeat experience as co-hosts, not just quizmasters?
I have loved it, but I'm in awe of both of your knowledge. It is very impressive.
Yeah, same here. Thank you very much again for letting us both join.
I think we're useful in a very niche pub quiz. Have a fantastic rest of your Christmas, guys. Thanks for your time. It's massively appreciated. And Jose, fantastic challenge.
Yeah, I want a rematch. Let's make the special Easter
New Year special
podcast. And I'll take a week off just to read.
Yeah, I'm studying for the next one. Especially, I'm going to be reading into the alpaca complex congenital heart disease.
And I'll check all the most recent guidelines.
Oh my goodness, absolutely. I think we should say thank you most of all to the listeners for tuning in and playing along. I sincerely hope all the links have worked.
Yeah, thank you very much, everyone, and happy Christmas.
Thank you. Happy Christmas.
Merry Christmas.
We love our listeners and the fact that people tune in, especially at this time of year. Have a good Christmas 2024 and a fantastic 2025, and hopefully we will all be seeing you again in the springtime.